we would start the last session number 7. It is great honor to welcome Dr. Eleanor, one of the eminent researchers in signaling pathway for insulin secretion. Welcome.
Is this on? Can everybody hear me? Yes? Okay. It's my pleasure to be co-chairing this last session with Ahmed here. And it's a delight to see so many of you still here. And it is also my great delight to invite Leszek once again to come up to the podium. I'm very concerned about your voice, Leszek, but goals of diabetes treatment. Leszek.
Okay, thank you very much, and I apologize for the delay. Mrs. Chairperson, Chair Lady and Chairpersons, I apologize for the delay, but we had a very busy workshop with plenty of questions. Yes, that's my final presentation during this course. It's been going very well. We are all excited that we are here, and we very much appreciate your interest and involvement with first of all workshops, because this is where the most interaction takes place. We will have the opportunity to say a few thank you words when we finish this session. Yes, just to summarize in a way of what we were talking for the last 3 days, I would like to briefly discuss the goals of diabetes treatment for you. The goals could be, well, there are several different levels of those goals. The picture I showed you before, this is the one most important goal. We want to preserve this type of very nice, this is a digital picture of the endothelium. We want to preserve it in patients who just started to have diabetes, and not to turn it into this very much calcified aorta. So that's one goal. And this is also the reason this is something which constitutes diabetes as a serious disease. If endothelial cells were not insulin independent, so if they required insulin to digest glucose, we would never see anything like that in our patients. Because when there is no insulin action, glucose wouldn't enter endothelial cells, they wouldn't be damaged. It would be exactly the same way as it happens with the muscles. We don't talk about complications of diabetes in the muscles, because without insulin, glucose do not enter muscular cells, and then they don't get damaged. But unfortunately, or fortunately, we don't know, but for diabetes it's pretty unfortunate, those endothelial cells will absorb glucose in a very just alongside the concentration of glucose in the blood, and eventually we will see the picture on the right. So to prevent it, just let's go backward. Yes, we want to, as a goal, we want to achieve this, so how can we do it? The information or the solution came 15 years ago, almost, from the STINO2 study. I also showed you this picture already, when they used multiple treatment, multifactorial therapy. This is the coined term, multifactorial therapy we use in diabetes, and they managed to achieve a very significant reduction, whether in its stroke, myocardial infarction, or coronary angioplastic procedures, including bypass grafting. And even if the statistical significance is not sometimes up to scratch, as you can see here, still the reduction was apparent. And the main message from STINO2 study, that if you treat patients according to several targets, not just targeting blood glucose, you decrease macrovascular complication risk for about 50%. And this was confirmed in later parts of the study, because now we have up to 13 years of follow-up in these patients. What they did at the time, I talked about hypertension. I showed you this target 130/80, but in diabetes they set the goal of 6.5% of hemoglobin A1c. This was somehow arbitrarily set. We know that the normal upper threshold level for HbA1c is 6%. If you ever do screening, we did several times where I used to work, the control groups from students, made from students for various studies. On average, HbA1c was 5.2, 5.3. So 6 is the upper limit. They said, let's make it below 6.5, just a little bit away from normal glucose, just to decrease the risk of hypoglycemia. This was the whole idea. And we used this threshold for the next decade for HbA1c. Actually, if you look here, and if you look at any guidelines or recommendations published at the beginning of the last decade, 2001, 2, 3, 4, this was the set of the targets which was advocated based on STENO2 study. So this study was very important and influential in making us think or creating the whole concept of target treatment, treating to target, and these were the targets which were taken from STENO2 study. But then the ACCORD study arrived, and I also showed you that they set the 6.5 as the target in these patients. They achieved that in intensive therapy group, but the patients were dying more often. The risk of death was increased by 25%. Intensive study arm was stopped. And this was the moment when we learned that we no longer can talk about one goal of diabetes treatment and glucose control. There were two groups of patients who benefited from this intensive therapy. There were patients who were basically healthier, with no cardiovascular event and lower glycated hemoglobin at baseline, but all the others did not benefit from this therapy. So we started to think, okay, we have to be able to differentiate the patient, and this is where the word individualized therapy came from this single study. I also showed you our part in the discussion from our department. We suggested, actually this article is kind of a funny story, because the ACCORD study results was interpreted very weirdly sometimes. Our article was a reply to the publication, to the article written by John Yudkin. You might have heard the name. It's a very well-known epidemiologist involved in diabetes care organization in Africa, a very bright person, now long retired. But he wrote an article. He said, well, if you have diabetes, you don't really have to treat it. Only when HbA1c is over 10%, you should do something. And we disagreed, and we thought, no, that's not true. Actually, we should diversify the targets, and that's what we suggested just as a voice in a discussion. The newly diagnosed uncomplicated diabetes 6.5. If you have, like, let's say 10 years of diabetes and moderately complicated 7.5. And if you're a long-standing diabetic with many complications and comorbidities, 8.5 should be fine. And as you know, this was eventually, it's not because we wrote it, it's simply most of the experts shared this view. American clinical endocrinologists also say 8.5 as the target for patients with advanced diabetes. So now perhaps we thought, until again I think very recently, we thought, okay, now we know. We have to set a very ambitious target in patients who are younger, just to, when their vasculature is intact, as this new vessel, as I showed you in the first picture, to bring blood glucose down and keep it like that. And in patients in whom vasculature has already been damaged because it was subject to hyperglycemia for many years, bringing glucose that low is probably dangerous, so HbA1c could stay at a higher level. So this all evolved in this figure, which was first published in 2012. This was the first edition of a ADA EASD statement published after ACCORD, Veterans and Advanced Studies. There were 3 studies which influenced this thinking and took us to the era of individualization of care. And this is the second version of this from 2015. After 3 years, this document is usually updated every 3 years. The next version is expected next year. And this is somehow complicated, but that really tells us how we should pursue treatment of diabetes. So the main goal is more or less 7%, but then we can individualize it both ways. If we have a patient with low risk of hypoglycemia, so usually a younger one, not after stroke, with perfect awareness of hypoglycemia, and someone whom hypoglycemia will not kill them, like it mustn't be an elderly person, with newly diagnosed diabetes, long expectancy, so relatively young person, with no other diseases or very few, no complications, a motivated person, and also with some money, able to pay for the treatment. We may be very aggressive, or we may set very ambitious goals. On the other side of this spectrum, if we have patients in whom hypoglycemia should be avoided at any cost because it might kill them, and they have a long duration of diabetes, short life expectancy because they're simply in advanced age, many comorbidities, developed complications, and they're also tired with all these diseases, and they don't have too much money to pay for the treatment, then probably we shouldn't be that aggressive. The argument for this is because if someone doesn't understand diabetes, they might say, oh, that's a nasty picture, because you suggest that if you're old and sick, you don't treat them. No, but that's not true. Also from the ACCORD study, we learned that those people who died more often in intensively studied group, these were the patients who, despite being in intensive treatment group, kept their HbA1c very high. 8, 9, 10%. So again, the lesson from the ACCORD study was that if you have a patient who is, it's not a nice term, but if they are so-called non-compliant, or somehow the treatment cannot be successful, let it go. I mean, don't fight with the patient, try to improve the treatment, but if there is no response, and the patient is kind of a complicated, with many complications, patients let it go. So this is the picture, which is also based on the ACCORD study results. So how can you do it? So that's one way of looking at it. You have a patient in front of you, you have 7 domains here, 1, 2, 3, 4, 5, 6, 7, and then you put somewhere on these axes, you decide what sort of patient is it. And that's just an example. If you have a 63-year-old patient who had type 2 diabetes for almost, let's say, 9-10 years, he's treated with sulfonylurea on insulin, so his risk of hypo is relatively high. He's 63, he's been with the disease for some time, so he's not that much motivated, but still he thinks I'm only 63, so I should do something with my health. 63, let's say it's not the end of your life, so you might still have expect some years of life ahead of you, of course. Has some microalbuminuria, so already have some comorbidities and suffered myocardial infarction, and works still as a health insurance employee, and does not have much money here. He's not a businessman, he's just an employee in a big corporation. So you may think, okay, so the result of this analysis will put him somewhere here between 7 and 7.5. But of course we don't draw the figures like that with every patient. We don't have time. We have to do it quickly, just based on our clinical experience, clinical thinking, but we have to learn how to do it. And the questions we have looking at this figure nowadays is, okay, there he is, this, let's say, 48-year-old person with 3 years history of type 2 diabetes, but who had just had myocardial infarction. So he is somewhere here. He is recently diagnosed. He has long life expectancy, but he has important comorbidity, coronary heart disease, and he has developed complications. So where is he? Should we go for close to 8, or we should close to 6.5? And that's a difficult question, but there is an answer to it, which I will tell you how I think nowadays we should look at patients like that. And just to show you some help, that's what the modern technology comes with, some help, because this figure here, this kind of algorithm, has been used to prepare, but it's actually a friend of mine, but I would show you even if I didn't know the guy, by Dr. Roger Lehmann. He's from Zurich, he works in Switzerland. And he, together with MSD company, they made this app, which is called Glycemizer. You can't have it on your computer, but you can have it on your iPhone or any Android device. It's free. And you put a few relevant information on the screen, and you get the eventual target for the patient. So you can use it just to help you calculate what sort of target the patient should have. And also the patient could use it. You could show it to your patient. Look, I have this smart app, and it tells you your HbA1c should be 7 or 7.8 or 6.8 or whatever. So if you want to have some fun with new technologies in type 2 diabetes, you can use this application as well. But then this is the reality. That's the picture I took in one of my, but one of the outpatient diabetes clinic in Poland. And I like this picture because it really shows you types of patients we all see. All people here have diabetes, all of them. It could be a family practitioner practice as well, because who can you see? You can see a man in his early 30s. I can tell you he's ready to jump to the doctor's room. This is the door of the doctor's room, office. This lady is standing here and is thinking, oh, can I go before him? Can I jump just before him? He's ready to jump in. And that guy here is also thinking, oh, could I do something to jump in front of him? That's the atmosphere of our outpatient rooms. The patient, of course, there is a queue. They have appointments at some time, but there are always people who are more or less impatient. But you also have this lady here. Let's say she's in her 40s, early 40s perhaps, or late 40s, professionally active, also has diabetes. Then you have that lady here. She's a retired pensioner, but very much well looked after, quite well off probably, very active with her grandkids. And then you have this gentleman here, who's an elderly gentleman, not really much involved in looking after his disease. And we all have to tailor the therapy to all these people. And I think it's very obvious for all of you and for all of us that this patient here, this young guy, needs absolutely different approach than this older man here. So now the era of having one goal for all the patients is gone for good. The question is how safely set the goal for all these different types of patients. And then we have this algorithms we keep showing all the time with those nice colorful rectangular figures here, and you should like it in particular because you might have not noticed before that it's actually a pyramid, because this blue thing here is the first layer, healthy eating and so on. This is non-pharmacological behavior. On top of this goes this pinkish layer with metformin, and on top of that goes other colored rectangles with other colors. So it is a pyramid. You have to look from top on this. But as we discussed in the workshop, it's not that helpful sometimes, because it really tells you can combine everything with everything here. The only differentiations is shown on the left. The drugs are different in terms of their efficacy, hypoglycemia risk, weight gain risk, side effects, and costs. But still it's not complete. We have also acarbose here. You may argue it might be used in some patients. So you might feel, especially at the very beginning, if you enter diabetes field, you might feel a little bit confused what to do and how to choose the drugs. But fortunately we have new studies arriving and they help us to decide. So I will show you a couple of slides with the data from the studies which should help make a decision how we should proceed with setting the goals and the strategy of treatment. This is the Lookahead Study, an extremely interesting study. If you've never heard about it, I would encourage you to go to the manuscript, to the paper. It's been published a few years ago in New England Journal of Medicine. A very long 10-year duration study. And this study was pretty simple in its design. They took a few thousands of people with impaired glucose tolerance with pre-diabetes or early diabetes, but still almost 20% was already treated with insulin in this study. And they randomized them to intensified lifestyle management or the control group. So the patients with intensive lifestyle group underwent the really intensive lifestyle management. They had classes for aerobics, they have dietitian visits, regular visits, and so on and so on. And look what happened. The question for the study, the aim of the study was to assess if we introduce lifestyle changes in patients with diabetes or pre-diabetes, will we save lives? Will it simply decrease mortality? So a very relevant question, asking if what we believe is good, what we tell the patients to, again, eat less, exercise more, and so on, does it translate into longer life? So the patients, apparently, they lost weight, as you can see, quite nicely, 8 kilos in the first year, then they gained, but still they remained at a lower weight level than the control groups. Their physical fitness increased, their waist circumference, so abdominal obesity, decreased. Even if it went up later, it was still lower than in the controls. Their glycated hemoglobin from 7.3, remember there were largely pre-diabetes or early diabetes patients, not so poorly controlled. For 7.3 it went to 6.6, then it went up, but still it was better than the control group. So you might say, oh wow, so it really works. People improve at the very beginning, then it deteriorates, but still it's better to do any lifestyle intervention or not to do it. But this is the result, the effect on mortality. Absolutely none. So the conclusion from the study, there are two main conclusions. One conclusion is that just by making people or introducing non-pharmacological treatment, we do not prolong their lives, we only make them die healthier. So they have better health indices, they have better HbA1c, everything improves, but they don't live longer. So they die healthier. That's okay, basically. I think this is what the modern medicine is about. It's very difficult to make us live longer. We will simply die in a better shape being. But the second conclusion was, excuse me, that it's probably the reason for this result was that all this lifestyle intervention was introduced too late. That you should do it in people who are obese, with normal blood glucose, definitely not in people with already advanced diabetes. So that's the one indication for a non-pharmacological treatment, that we should probably intervening at a pre-diabetes stage is already too late. And then there is the major change in our view of type 2 diabetes therapies, which comes from this single document. And that's the second part of the studies I want to comment upon. This is the document from December 2008, published by FDA. And this made the companies organized all those cardiovascular safety trials, cardiovascular outcome trials. Why FDA did that? You might remember drugs like dexfenfluramine, early 90s, for obesity treatment. It was called Izolipan in Europe. It was produced by Servier. It was the centrally acting agent to decrease appetite. Then there we had sibutramine, Meridia. These two drugs were withdrawn due to side effects. Dexfenfluramine caused valvular disease in the heart. Sibutramine increased the risk of myocardial infarction in the elderly patients. Then we had serivastatin, a very powerful statin, but which was extremely hepatotoxic. We have rimonabant, again an obesity drug, but the drug which increased depression risk and made people commit suicides. And the last failure in this metabolic active agents was rosiglitazone, which was suspected of myocardial infarctions. It wasn't confirmed, but this was the story behind this drug. And after these few blunders, FDA said, okay, we mustn't go on like this, especially after rosiglitazone. We will register the drugs and we will license the drugs to treat type 2 diabetes, but they have to be also shown to be safe from cardiovascular point of view. And they issued this document, a guidance for industry, that the drugs should be evaluated at cardiovascular risk. And as they say in the industry, if FDA tells you to jump, you jump. If they tell you lie down, you lie down. You do whatever they want you to do, because American market is the best market for any drug company. So this is the list, and I know you can't read it, but it's not to be read, but this is the list of all the studies which were initiated as the result from this guidance. Oh, thank you. Thank you. And if you calculate there's a number of patients taking part in this study, in this resolution is absolutely non-readable, but it all comes up to 166,000 of participants in this cardiovascular outcome trials. This is an enormous amount of patients. This will also be an enormous amount of data, which we will learn a lot about the drugs. We already do. And they already started to change our view on how we should proceed with treatment and setting the goals. This figure shows the timeline of publication of the results of the studies. The publication started in 2013. You can see here, this was the SAVOR study, was published, an examine study. They were the first one to be published. All those studies were made due to FDA requirement. And as of today, we have these 11 studies published already. So quite a lot of data. And I could spend another 2 hours discussing in details what they come up with, but I will just summarize it quickly because they will influence largely the way we treat the patients. You'll see the next ADA EASD statement. It will be heavily relying on the results from these studies. Importantly, all the new drugs, these are the drugs groups which are studied. So DPP-4 inhibitors, it's GLP-1 receptor agonists in yellow, and SGLT2 inhibitors, and one insulin. This is a DEVOTE study which was discussed already yesterday. So what we learned, the 3 studies were just, the 2 Canvas studies and DEVOTE were published, for example, very recently in Lisbon, together with Excel study. There are 2 things before I summarize what we know briefly. There are 2 things to remember whenever you listen about these studies. One thing, this is from MPAREG outcome, the characteristics of the baseline characteristics of the study groups in terms of cardiovascular risk. But you could see it in almost every study like that the patients who took part in these studies are not newly diagnosed, by no means. They have type 2 diabetes for usually over 10 years, and they are at high cardiovascular risk. Look here. 3/4 of these patients in MPAREG outcome trial had coronary artery disease. Half of them already suffered myocardial infarction. 1/4 had stroke. This is not our typical group of patients. These are the patients at this more right-hand part of this figure when we decide whether we go to the less or more stringent glucose control. So first of all, the results from these studies can easily be translated into our clinical practice, but largely to this group of patients. The more sick, with more advanced, with more complications, particularly, of course, cardiovascular disease. And the second thing you should remember is that in any large trial, the patients which are studies look more or less like that. Of course, they're not the patients you recognize, the famous actor and the famous singer. I mean, they're kind of ideal patients. Yes, they have to fulfill inclusion criteria. They have to follow the protocol. The doctors who invite patients to take part in the studies are, we never invite patients who are difficult patients, whom we cannot talk to or who do not come to the visits. So this is a kind of it's not a good representation. It is a sort of representation, but they are the best patients you can have, fulfilling the criteria and also easy to collaborate with. While in real practice, when you go to your office, this is what you see in everyday practice. This is your patients you see every day. So they are similar, but not necessarily the same you see in large trials. So this is also you should remember when we try to understand what the big trials are really about. So what were the results? The first 4 studies, SAVOR, EXAMINE, TICOS, and ELIXA, 3 of them on DPP-4, saxagliptin, sitagliptin, alogliptin, they were all, let's say, negative. They didn't show additional benefit, but they simply showed cardiovascular safety. There were no risks associated with these drugs, and this was what these studies were about. They were not about showing, oh, these drugs are better than just, they do more than just lower blood glucose. There is something else. Also, the study with lixisenatide showed safety, no additional benefits. But then 2 years ago we had EMPA-REG outcome, and almost 2 years ago we had LEADER study published, and this was really a breakthrough, especially EMPA-REG with empagliflozin. We had 14% reduction in the 3-point MACE endpoint. MACE is major arteriovascular acute coronary events, MACE, adverse coronary event, adverse cardiovascular events, MACE, yes, thank you. And this primary endpoint is recommended by FDA. So all these studies are nice to compare because they use the same 3-point MACE. And this 3-point MACE consists of myocardial or consists of cardiovascular death and non-fatal myocardial infarction or stroke. So basically all cases of myocardial infarction or stroke, because cardiovascular death is usually MI or stroke. So in EMPA-REG outcome, they achieved 14% statistical significant reduction in MACE, and in LEADER 13%. There were differences, like we know in EMPA-REG outcome it was mostly driven by improvement in heart failure risk. The empagliflozin apparently helps heart which is failing due to the MI. And in liraglutide, the onset of this reduction appeared much later, after a year, and the mechanism must be really different than in SGLT2 inhibitor. But nevertheless, we have suddenly 2 drugs which we use quite widely with additional benefits. And as I said, especially EMPA-REG outcome was very significant, because what you can see here is the reduction by 38% in cardiovascular deaths. And this reduction occurs very early on, after 1, 2, 3 weeks of the drug use. So this is sort of amazing, and we are pretty sure that this is not because this drug lowers blood glucose. There is no way lowering blood glucose will save lives in a month. It's some other mechanisms, hemodynamic for sure, but perhaps associated with increased glucagon levels, because empagliflozin increases, like all SGLT2 inhibitors, they increase glucagon. This is the picture from the LEADER study with liraglutide. You see the benefit of the drug is appearing after year and a half, and the decrease in cardiovascular death is about 22%. So more or less half of what is achieved in empagliflozin. Still significant, still important. So if we go back to this pyramid again, we should look at it very differently today. There is nothing about cardiovascular risk reduction, because when it was done, we did not have the results of the study. And clearly 2 groups of drugs are becoming much more prominent than the others. And it's SGLT2 inhibitors and GLP-1 receptor agonists, as these are the drugs who, apart from lowering blood glucose, offer something else. The big questions we are having now is, we should prescribe, and that's what we do, for example, well, in my country where I work. When the moment we have a patient with myocardial infarction who comes to us and has a history of MI, even before he develops or she develops diabetes, we put him on metformin and empagliflozin. Because how can you deny a drug which decreases the risk of death by 40% in 3-4 years' time in patients after MI? We would probably be even more happier with prescribing liraglutide in obese patients, but this is simply 5 times more expensive. So this needs clearly updating, but the big question, as I said, is, are these results also true in patients without cardiovascular disease? Will these drugs also save lives in patients without already developed, simply newly diagnosed type 2 diabetes patients? Well, we don't know from the studies. We might suspect, but we don't know. So perhaps we should have new algorithms to achieve these different goals. Perhaps in patients, and that's just my speculations, that's nothing official, I'm just sharing my thoughts with you, trying or encouraging you to think a little bit out of the box and to be a little bit more active in tailoring the treatment. Perhaps patients with diabetes without cardiovascular disease, we should start, of course, with metformin, then use DPP-4 inhibitors as they are very safe, no hypos, you don't have to talk to patients at all about any side effects. And the earlier they are used, the more effective they are. Because if you use DPP-4 inhibitors in patients who are already on insulin, they are little effective. Then perhaps you might use sulfonylurea, but I would rather put today SGLT2 inhibitor as a third one and sulfonylurea as a fourth one. But you can use all these 4 drugs together, again outside of this algorithm I showed you a moment ago, because they don't say 4 drugs are possible. But we see increasing number of patients with oral medication for different drugs. But if a patient has cardiovascular disease, the approach should be different. And I'm strongly convinced to this approach. The patient should have SGLT2 inhibitor, then GLP-1 receptor agonist, liraglutide, and then pioglitazone, perhaps, because pioglitazone has also some nice data in terms of cardiovascular protection. So, and this is the ultimate goal of diabetes treatment, not just to lower blood glucose for lowering blood glucose. We have to be able to save lives, and this is what the current studies, or the most recently published studies, tell us to do. So just to summarize, I think this is how we should go about. We should diagnose and treat patients as early as possible. Lookahead Study showed us that if we introduce lifestyle changes in pre-diabetes, in early diabetes, we'll improve quality of life, but we won't save lives. So we should detect diabetes early and act quite intensively from very early on. I don't think we should be afraid of multiple drug combination, because I also showed you 2 days ago how complicated and complex type 2 diabetes pathophysiology is. So early multiple treatment is probably the good way to go. And absolutely individualization of the treatment is crucial. Patients who are younger, but it's not ageism, it's just they're younger, it means their diabetes is less advanced and they have fewer complications. They should be treated more intensively. Those with greater number of complications could be treated in a less stringent way. But this is the answer to the question what to do with this 48-year-old man after myocardial infarction. And this is the latest addition, and in all the discussions I take part, this is what the conclusion we come up to, that actually we could treat intensively patients even with advanced diabetes only if we do not increase the risk of hypoglycemia. And this is absolutely possible if we use the drugs which do not cause hypo. And just let me go back quickly to this. If you look at this bottom line here, all these drugs here, metformin, SGLT2 inhibitor, GLP-1 receptor agonist, and pioglitazone, they don't cause hypoglycemia. And they are quite powerful. Each of them is quite powerful in lowering blood glucose. So I think this is the next step, not just individualization, not just using SGLT2 or GLP-1 receptor agonists in people with cardiovascular disease, but also using all these drugs to intensify the treatment, to get the blood glucose as low as it is only possible or advisable, but without the risk of hypo. And we are very close to this target. You may ask, okay, but there is no room for insulin here then. No, there is a room. There is a room. Many of our patients, on average in my country, the patients need insulin after 6 to 8 years of type 2 diabetes. Most patients after 10 years of diabetes, type 2 diabetes, has to be treated with insulin. We cannot simply get more from beta cells, but we will introduce it later. And what we now see from rich countries, the best way to introduce long-acting insulin would be to combine it with GLP-1 receptor agonists, because we use lower doses of insulin, we decrease the risk of hypo and decrease the risk of weight gain. And as one more point for individualization, what I just said, we should choose the drugs according to presence of cardiovascular disease. And the final point is, and it all came from this ACCORD study that we learned in the last decade, that whatever we could do, and this is the bottom line. I also tell the patients, if they come, sometimes they come to me and say, it's too complicated. I can't do all these things. I can't remember about all the things you and your nurse told me. I can only do one thing. So I said, okay, if there's only one thing you can do, treat yourself or take the drugs, or we will be looking only to avoid hypoglycemia. Even if your blood glucose is slightly higher, you mustn't have hypo. That's the current understanding of getting diabetes treatment to the goal. Thank you very much for your attention.
Thanks very much, Leszek. I will take questions at the end.
Yeah,
I think that would be easier, just to make sure that we stay on time. I'm going to hand over to my co-chair now to introduce the next speaker.
I think it will be an overlap between the two lectures, the past and the lecture by Dr. Omar. Overlap between the goals of treatment and algorithm for type 2 diabetes. Might be an overlap between these two lectures. We will hear Dr. Omar first, and then we will discuss. Okay?
مساء الخير عليكم. I'm seeing how many here. Okay, I was asked to do a very interesting topic. طلب مني الآتي: algorithms in diabetes. نقطة. I said, why not? Let's try it. Let's try to do it and see what algorithms do and how did they evolve in the picture. So, first of all, what are medical algorithms? إيه قصتهم? Secondly, why use algorithms? And thirdly, let's take examples of diabetic algorithms and what to do with them. So, medical algorithms. A medical algorithm is any computation, formula, statistic survey, or more than 3 pictures, which is a nomogram, or a lookup table, useful in healthcare. Anything that will give me guidance. Medical algorithms include decision tree approaches to healthcare, and they help us in the treatment and using the tools, and at the same time it can define the uncertainty. Medical algorithms are a part of a broader field which usually fits under the aim of medical information and medical decision making. Medical decision occurs in areas of medical activity, including diagnosis, selection of patients, therapy, and prognosis. Okay, what is the intended purpose of a medical algorithm? To improve and standardize the decision made in delivering the medical care. I want to improve the service. Okay, it assists in standardizing selection and application of treatment. It is carefully tapered to reduce potential errors as much as possible. مفيش أخطاء. Some attempts to predict the outcome are done, especially in the area of critical care scoring and in the area of risk calculation. I can look at it and I know the risk is how much. So, computerized health diagnostic algorithms can provide the following. Number 1, clinical decision support. Number 2, improving the adherence of the patient. And number 3, a resource for education and research. medical algorithms based on best practice, not on clinical evidence, can assist everybody involved in delivery of standardizing treatment via a wide range of clinical care providers. Many are presented as protocols, and it is a key task in training to ensure people outside the protocol when it is necessary. How do I approach? If it is not written, then I must have another alternative. What to do? In our present state of knowledge, generated hints and producing guidelines may be less satisfying to the author, but are more applicable. What I say is, as much as possible, it should be evidence-based. However, in certain fields, it must be a personal opinion or a guidance to what you will do later on. So, why use algorithms? Easy to read and follow up. When you look at it, it's easy. I hate the slides that are very crowded. It should be very clear, done in a very simple way. It should cover different aspects of the disease that I am giving the algorithms on, whether it is diagnosis or management. Every step should be covered, and it should be easy when you look at it. It should be updated with the latest knowledge. Every year it should be updated. It should be more evidence-based, but without, sometimes evidence-based does not cover a field. So at this instant, I can use certain opinions and less personal experience as much as possible, if there is no... Okay. What about the slide that you look in? I prefer the following. It should be clear and easy to follow. Simple colors, simple background, everything should be very easy in it. It gives a comprehensive way to diagnose if I'm doing a diagnostic slide. It has an easy way to follow it up. Not many curves and many arrows. It will be very difficult for you to follow. It should be easy and updated every year, 2 or so. Colors play a very important role. Yesterday, I saw a very interesting from the lady from Greece. For the first time, I saw what you see for the fever when you thermometer, which is in English. She put it, and she put the red and the green, and she put data over it. This was the first time I ever see something like this. When you put it under your mouth to see the temperature, she used it as an indicator and put everything in it. Less text and more diagrams are better. Okay, let's take examples. In diabetes, first algorithms that were ever done were for the treatment of complications like hypoglycemia. These were the very first. However, type 2 diabetes took a lot of algorithms in the following, starting from 2000, I think, and 1, 2003, 2009, 2013, and every time they changed and changed and changed it, and they updated them. Okay, do you remember this algorithm? This was from the very, very early versions, first appeared 2003, and then it was updated 2013. Look at it, you'll find that it is clear and to the point, without many colors, and it is applicable. They did the following. They said that if you have an A1C 6.5 to 7.5, you start with one drug. And they put at that time the drugs that were available. Those who were not available were not put at that time. And it was 10 years ago maybe. And then if after 3 months it did not work, they added metformin plus the other drugs. And then after another 3 months, they added a triple drug. Okay, this is for the A1C, which was 6.5 to 7.5. For the other A1Cs, which is from 7.6 to 9, newly diagnosed, they put the other algorithm, which has start by 2 drugs, metformin if the patient can tolerate it, plus any drug you'd like. At that time, they put a DPP or a TZD or a GLP, first choice, because it doesn't cause hypoglycemia. And then they put the second choice, the drugs that we all know, sulfonylureas, اللي بتعصر البنكرياس زي ما بيقولوا. Okay. And then after 3 months, if it doesn't work, add another drug. What do you see in Egypt here? I see the patient left for 3 years on DPP4 and on something else, and when you come to change, he's going to tell you, no, you're going to destroy my pancreas. This is very wrong, because you say every 3 months you should reevaluate. Your maximum is 8 months and you must change or put something else, okay? No, another 2 to 3 months, add insulin. Not leave it for 5 years, as the drug companies say. This is a crime. The third one, if you have a sugar above 9, and this was 2000, I think 12, this algorithm. Look, it's very simple. If he is symptomatic, give insulin. If he is not symptomatic and he did not take oral, give oral. And start by 2 to 3 drugs. Very simple in approach, and no colors, no much colors, and at the same time, you can understand it when you see it. This is the full-blown picture of the first American Association of Clinical Endocrinology, and it was one of the loveliest diagrams that we saw. Look at this. While you're driving the car, you have a green light, pass. You have a yellow light, please take care, and red, do not pass. They put everything in the table, and they put the blue is it's all right, and then they put the different colors with each drug, which to use, when to stop. أخضر ما تطلعش. قصدي you pass the road. If it is red, you should not pass the road, and yellow, please take care. Okay. Then a revision happened to this diagram. This revision used colors for the first time, and they were lovely. Look at it and see. Green, which is all right, 6 or 6.5, the A1C should go down to this. Yellow, which is take care in the old age. You might have hypoglycemia. Now, the first time I saw this, I'm very interested in art and music and playing and things like this. The first time I saw this, wow. Look at the colors. Look at how they did it. Look at the contrastings. The one who did this diagram deserves a Nobel Prize. Why? Look at the colors. If it is green, it's all right. It doesn't cause hypoglycemia, and it will be an asset with fewer side effects, and it will improve the function of the pancreas. If it is yellow, it's good, but please take care. When I was in Turkey last year, I decided to go by the law. I wanted to pass the street in Nishantashi. I just wanted to cross the street. So I decided not to do as we do in Egypt and pass, or Turkey. I will wait until the green light comes. I waited and I passed. What happened? The taxi was going to kill me. And he came over the pavement and started insulting me. What? This is a green light. So he told me, in Turkey, we don't do this. You pass anytime. This is wrong. What we say is the following, please. Green is very good. Look at this. The same diagram exactly, but from 7.5, they put the very safe and then the less safe from the point of view of hypoglycemia. And then after 3 months, they put a red dot with a side, which is shift to the other one, which is double therapy. Metformin plus whatever you like. But please take care not to cause hypoglycemia, as my other person said, doctors. And then after 3 months, if it doesn't work, then put 3 drugs, and at that side you are justified to do any combination as you see. Well, after 3 months, or if your entry is 9, exactly like the other one, but they put colors in it and they put a diagram in it. Then, if he's symptomatic, give insulin. If he's not symptomatic, do not give insulin. Now look at this. This was one of the most beautiful algorithms for insulin, and it's an old one. What did they see? Well, you have, if you want to start basal insulin and you want to intensify it, basal insulin, you should start with the least possible dose, 0.1. They put it in green to 0.2 of the body weight. Most companies say 10 units. Well, in our country, average person is about 90. That means 9 units, 110 units, which is okay if it is 0.1. And if it's 0.2, then it would be 20, okay? When you intensify, just instead of 0.1, make it 0.2. And instead of 0.2, make it 0.4. We don't ever start with 40 in the morning and 20 units at night. This is a crime that we see, or just give once 50. This is a punishable crime, Okay? And again, they said what? It is very safe to start with the small dose, not to kill the patient. And they put it in green, which is you can safely cross the road. And then they put the algorithm above 180, they put it down, and it is in blue color, which means there is no restrictions over it. You can either add 4 or 2 or 1 unit. 4 if it is above 180, fasting from 140 to 182 units, and so on. And they put everything in it in a very beautiful looking algorithm. The same thing they put here for dyslipidemia and hypertension. The same old thing. And at the same time for obesity, they put a same diagram, even though I don't like this diagram because of the colors in it. Most of them are red, which is take care. And you know that in treatment of obesity, you're only allowed one drug, orlistat, and sometimes metformin. Okay? Another remodification was done for the lifestyle. Look at it again. Lifestyle is in orange, which is take care of your lifestyle. And then they put red and green colors. And they say the following: please, if you get a patient with pre-diabetes, if he's hypertensive, or has a cardiovascular risk, or does he have impaired glucose tolerance, and each one of them they put in green. Please take care. When you find it in green, take a closer look. When you find it in red, it's not allowed to do it. Another modification 2 or 3 years ago, they did the same diagrams, but with the background in black. I usually prefer the white one, but in black it's very good. Okay? And they said what? Less than 7.5, more than 7.5, or above 9. All of them, they have a lifestyle modification, and then you should add it the same way. This time they said they put it in the form of a thermometer with an indicator that will go red, blue, or green. Well, it's good, but I prefer the older one. The same diagram for intensification like the old one, but this one is newer. However, it is in black for funerals. It should be in white to be more lively. And then they said that you should evaluate the cardiovascular risk in these patients. You should evaluate the cardiovascular risk in these patients, and please take care. Low is yellow, medium, and red. All of them, they changed the colors here. Instead of green, they put it all red, yellow, and orange. Again, step 1, to evaluate the complications, and step 2, if you need treatment, give it. If you look at it, it's a very nice diagram. But again, I say I prefer the white background. It is easier for the eye. Here is the same as the old one, which was mixed between the American Association of Clinical Endocrinology and other sites. And again, they started to put, it's working alone, and then they started to put everything in its place. Well, another very interesting algorithm was done, and this algorithm was by the Diabeetus Scale. First of all, the old version, they put everything in when to use and what and when not to use, and everything, what is its use and what is its side effect. And then they started, this was very famous at that time. First, give metformin because this is cheap. After 3 months it's and good, and anybody can afford it. After 3 months you can add any drug, and this was from the early versions. And then after this you can add a second drug for any combination, as we saw. Again, it's clear and the colors are very good in it. And at last, give insulin. Okay? And then another modification happened over it, and they said metformin. And then they started to put the non-injectables or non-insulin injectables in the table itself. Okay? And they started adding certain things, which is, if you are intolerant to metformin, don't start with it. Start with the sulfonylurea. And at the same time, please, if the A1C is high, give multiple therapies. Don't wait. The AGA, American Diabetic Association, also did these diagrams, which we saw several times. Please take care. The lower, the better. A1C is not good. Okay, it's sometimes needed, but it has its risk of hypoglycemia. So please individualize and see each patient alone. What is his need? Okay. This is the diagram that they did, the EGA. It's very simple, white background, give mono, or give after 3 months as lifestyle and the second drug, or lifestyle and the third drug. This is a standard exactly like the AACE, but it's in less colors and with a whiter background. If I get it more like this, it's a little bigger. First drug, metformin, or metformin plus whatever it is, or metformin triple therapy, any combination is accepted. But you individualize it. Don't tell me his hypertension or edema lower limbs and put pioglitazone. This is terrible. You just judge what you're doing. Okay? And for the insulin, they did this diagram for the injectables, either basal or other. And to my knowledge, they are combining today the GLP with the insulins. I can't combine this in our country. It would be too damn expensive. I can't do this. And I can't, at the same time, I attended a lecture outside Egypt, which said, treat to target and treat to failure. And when he said treat to failure, he meant what we do. He wants everybody, when you start, you must give him a GLP and a TZD. This is terrible. But this was a point of view that the Americans put it in consideration and does it. This is the Canadian guidelines. Again, it's done in a very nice way. It says, please get to target in 6 months maximum. Don't wait. Initial choice of therapy depends on polyuria, polydipsia, weight loss, metabolic. What does this patient have? Then, please, concern about insulin deficiency. Is he type 1 or 2? Is he deficient or not? And please, either you will give insulin or metformin or combinations. You are the judge of this condition. A1C low than 8.5, start with metformin and reassess after 3 months, not after 2 years as drug companies say. 3 months is your maximum, you change to another one, okay? And if the initial is more than 8.5, then you should consider gradual entering with drugs or addition of insulin early. Please individualize. نقي اللي انت هتديه. Nothing is to be given. There is nothing for all patients alike. We don't do this. Okay? Look at this. You have a priority if he has hypertension or cardiovascular risk. Choose. Don't be hesitant. Look at the diagram that the Canadians did. White, nothing in it. Very clear. What did they say? Start by lifestyle and metformin. And then if the A1C is less than 8.5, gives this. More than 8.5, give this. Start metformin immediately or combinations if it is above 8.5 and not symptomatizing. If not at all glycemic targets are met, then you should do this. And I hate this step. They said the priority, follow the MPREG and follow the GLP. And what I see is ridiculous. Cardiologists starting to treat diabetes and giving it in lectures, saying to every patient, you start with GLP and the drugs that act on the kidney, Invokana or Guardians or Forxiga. Well, it's very good. It's very good for us because they don't know the price. They cannot follow up the patient. So the patient will leave them and come back to you. They put a prescription with a very high cost, and they are cardiologists. I don't know why they do this. We never should do that at all. Okay? The last thing I want to do is another set of diagrams or algorithms were done in the form of questions and answers. You put the question and you answer it in the form of diagram. What are the targets in the hospital for treatment? What are the targets? And they put it in a clear-cut diagram. This is for the hospital. what should be your blood sugar from 140 and 280. Another question, what to do for lifestyle? Very clear. When you look at it, there is no mistake in it. It's small and very concise and to the point. The same thing, what to eat and not to what to eat. The carbohydrates are how much, the fats are how much. When I look at a diagram like this, I will never get mixed up. It's very clear and to the point. Look at this, insulin regimens. Insulin is required for type 1. Okay, end of story. If I give insulin, will I give it multiple daily injections? A question. Or continuous subcutaneous? This has its indications and this has, and there is no mix up between them. If you have hypoglycemia, what do you do? Well, it's mild, moderate, and severe. What is the blood sugar level? If he is able to help himself, it's either mild to moderate. If somebody is needed, then it is severe. And look at it, very simple. When you just look, you can understand, oh yes, these are people who know what they are doing. Not a diagram like this and one like this and another like this, and you say, what the hell is this? And you start getting a pencil and paper and start doing it. Look at the early and the later diagrams for hypoglycemia. If you have less than 70, this is a triggering, which has been reduced after this to 54. What do we do? Patient is alert, that's type 1 or 2, mild or moderate, and patient is not aware or alert, the other side. Very simple, nothing to do, and it will not mix you up. The same thing for lipid management. There are several diagrams that when you look at, you can manage the lipids. Okay? Again, what about the non-pregnant ladies? I think this was a repeat for the other slides. What about the pregnant women? Wow. I find the women coming to you in the clinic and say, the doctor wants me fasting 99 and postprandial 120 or 30. Sometimes this is impossible. But what about before lunch? What about after lunch? What about at night? And at the same time, look, it's very clear. Look at pre-existing type 1 and type 2. These are very stringent, very strange. The upper ones, yes, we can do them. But again, they put them when to look for these and when to look for these. Please remember, comprehensive management of a diabetic team is the following. I am not the Iron Man or Superman to take everything myself. No. I mean, I need somebody for psychiatry, I need a dietitian, I need a nurse, I need, if I need somebody for his foot, then a surgeon. So it must be an integrated diabetes team to treat the patient as much as possible and to take care of him. And thank you very much.
Thank you, Dr. Omar. Do you think any debate about guidelines?
What?
Debate about guidelines?
مش فاهم، وضح سؤالك.
Debate about guidelines. دي ممكن تبقى سيشن لوحدها في وقت تاني.
What I hate some of our senior professors, when you ask him a question, he says to me, I am above the guidelines. What's this? There is nothing called I'm above the guidelines. Okay, in diabetes it is clear. But what about I'm in cortisol levels which are high? What about in hyperparathyroidism and you cannot know the source of calcium? What about in growth hormone and you remove the tumor? Would you give in the pituitary? Would you give or not? These things are not debatable. What I say, yes, you have a very nice idea, we can do debates, but what I say is, these people spend a lot of money on guidelines. I cannot simply ignore them. I must know what they are doing and try to implicate it. Sometimes it's ridiculous when they tell me start with a GLP or a very expensive drug. But I must respect the guidelines. I must implicate them as much as possible. In my country, I do not start from zero. I see what these people do and I try to do it. If it is not in coordinates with me, okay, I will not do it. And at the same time, guidelines are not, they change every 2 to 3 years. So I must be open-minded also. But in diabetes, it is clear. But there are other areas of endocrine, it's not clear at all. You must stick to the guidelines. I will not do a personal opinion in this. And thank you.
Okay. Yeah, in diabetes, the treatment should be individualized for every patient.
Yes.
should be tailored for every patient. And now, the last lecture, obesity and diabetes, most of our patients, by Dr. Eleanor.
Thank you very much. There we are. The first thing I would like to do, thank Mr. Chairman for introducing me, but also to thank the organisers for inviting me to come along and give a talk today. I don't normally give a talk on diabetes and obesity. It's the first time I've ever presented at one of these meetings. So thank you for waiting until the bitter end. I thought I'd try to do something a little bit lighter, since you've sat here for 3 days now, and it's been quite intense. I've seen quite a lot of the talks, quite a lot of the workshops. So I'm going to talk a little bit about obesity and diabetes. So what exactly is that, and what are the different parameters, and how can we look to pull back on obesity? Now, this is some data. Now, forgive me, because I came in late on the first day of the course, so I don't know if you've seen some of this data already. Has anyone presented the new OECD data? No? Okay, this came out just a few weeks ago and showed that in the OECD, I think there's a group now of 35 countries that are part of that. You can see that over the years, the obesity trends are just increasing, and they're continuing to increase. America leads the way. You can see there are a lot of other countries that are where the obesity rates are increasing, and a lot of countries where you might not think they would increase. The UK holds the very dubious record now of being the fattest nation in Western Europe. And obesity is not, it's not particularly gender defined, but if you look at this data from the World Health Organization, if you look at specifically at the colors, the countries that are in the dark red, you can see that these are the age standardized prevalence of obesity in men. You can see that it's much more prevalent in women. I'll just go back, hopefully, to there. That's the men, that's the women. You can see that that's particularly an area of concern here in the MENA, the Middle East, North Africa region. And when it comes to body mass index, you'll all be familiar with this particular chart. And whilst most of us like to think that we sit over on the left-hand side of that, we don't. Most of us are sadly sitting over towards the right-hand side of this particular slide. And there's one set of data that I really like, and I like to show whenever I'm giving a talk on diabetes and obesity to other groups. And it's this. It's the obesity trends among US adults. Has this been shown? Have you? Who's familiar with this data? Yeah, thanks, Leszek. This data is shown routinely at diabetes conferences, and I'm a big fan of it. So the next few slides I'm going to run through very quickly. What you just need to look at is in the top, you'll see the date, and this is going to change by year from 1985 up to about, I think it's 2008 or 2009. And if you look at the colour coding along the bottom, you're going to look at obesity rates increasing. Now, in 1985, when the Centre for Disease Control started doing this, most of the states in America hadn't gathered this data, so they appear white. And then there's the pale blue and the medium blue. So if we start to look through this, now what I want you to do is to keep your eye on Mississippi. Now, that's not a line that you'll hear in many talks, but for those of you not familiar with which state Mississippi is, it's that one there. You can see that the colours are increasing, the number of states are increasing in dark blue. It's over a very short space of time. Mississippi introduces us to a new colour, to 15 to 19% of their population as having a BMI of over 30 or equal to 30. And Mississippi again introduces us to something that's over 20%, and this has only taken about 10 years. and over 25% of the population, and over 30%. So in the space of just 20 years, they have gone from, some states have gone from having a population of less than 10%, having a BMI of over 30, to over 30%. And that's where the data stopped, because I think at that point the CDC recognized that every diabetes conference was using these slides. You can still get hold of them, but they do the data analysis in a slightly different way now. I think that shows very nicely that the obesity in America, and that is the country that's really leading the way on obesity, has increased over a very short space of time. This is a quote from Rudolf Virchow, sorry, a German physician, who said that epidemics appear and often disappear without trace. When a new culture period has started, thus with leprosy and the English sweat was a highly contagious disease in the late 1400s, early 1500s. In the UK, it resulted in death almost immediately, certainly within a few hours. The history of epidemics is therefore in the history of disturbances in human culture. And we have evolved. Have we evolved in a good way? So what I'm going to look at is how we can perhaps reverse this, if indeed we can. What is driving the epidemic? So, hands up if you think that obesity is genetic. Remember, you're speaking to a geneticist here, so it would be good if a few more people put up their hands. Oh, just a few people. Who thinks it's environment? Who thinks type 2 is environment? Okay. And who thinks it's a combination? All right, that's more like it. So probably my job here is done. We may be able to go for lunch early, but essentially, obesity, as you know, is a mix of environmental causes and genetics. And I'm going to run through some of the environmental factors, and I'm going to finish with some of the genetic factors, assuming my voice holds out that long. So there's three different schools of thought about obesity and type 2 diabetes. I'm only talking about type 2 diabetes here, not type 1. And the first school of thought is, it's your fault. And quite frankly, if you're going to eat a burger that's the size of your head, then yes, maybe it is your fault. The other picture on the right-hand side of the slide is another very famous picture that you will see a lot at diabetes conferences, which is a gym where people are actually going up the escalator rather than going up the stairs. Oh. So the first thing you can do really is go on a diet, if it is your fault. And this paper, this is work of Roy Taylor, which some of you will be familiar with, at University of Newcastle. And what Roy did was he published this back in, I can't remember, it's a good few years ago now, published this in Diabetologia, looking to reverse, and I put reverse in inverted commas, to reverse type 2 diabetes through diet. And what he did was actually quite draconian. It was a very, very small study. If you look at the methods at the bottom, you'll see that this was actually only done in 11 people. But he garnered a huge amount of media coverage with this study for a good reason. So what he was trying to, he was hypothesizing that by putting people on a very, very strict diet, this is just 600 calories a day, he could reverse, and again I put that in inverted commas, he could reverse type 2 diabetes. And he looked at the usual outcomes. He looked at basal hepatic glucose output, he looked at peripheral insulin sensitivity, beta cell function, he used HOMA analysis to measure beta cell function, and he looked specifically at pancreatic and liver fat content, triacylglycerol content. And he showed that essentially you could reverse type 2 diabetes. The 11 people that he did on this original study were kept in the hospital research unit, so it was done under very, very strict surveillance. But he showed that type 2 diabetes could be reversed, and this was purely by dietary restriction. There was no exercise involved here. In fact, the patients were actively encouraged not to exercise. So he wanted to do this through diet. And he showed that it could be, type 2 diabetes could be reversed. But of course the big question was, well, if you stop eating just 600 calories a day, does your diabetes come back? So he went on to do several quite a lot bigger, the studies were a lot bigger. He did the Counterpoint study, which published in 2011. And it was a bigger study to show essentially the same thing, that a very low calorie diet would reverse type 2 diabetes. But it was the Counterbalance study, which published just last year, which showed that type 2 diabetes could remain reversible for up to 10 years. So a legacy effect, and legacy effects have been shown in various different studies now, including UK PDS. But there's a legacy effect which can last up to 10 years, and this is putting people on slightly more calories. They're allowed a slightly increased diet from 600. But it shows that normal metabolism persists in the long term, as long as that person doesn't regain weight, and that's the big issue here. So essentially, if you look at it as a sort of chain of thought, excess calories leads to excess fat in the liver. The liver then responds poorly to insulin and produces too much glucose. Excess fat in the liver is passed on to excess fat in the pancreas. That affects the beta cells, the insulin-producing cells in the islets of Langerhans, and the beta cells fail. But through losing just 1 gram of fat in the pancreas, 1 gram of fat in the pancreas, it can restart, it can trigger proper beta cell activity again and normal production of insulin. So those are really nice studies that shows that diet does work. But we all know that diet's really hard. Diet involves people being really motivated and wanting to lose weight. So why do that when you can have a little bit of surgery? And bariatric surgery has been increasing in popularity, and again, forgive me if some of these studies have already been, some of this data has already been shown to you. But bariatric surgery is increasing all over the globe, with a huge number of procedures being done in North America and across Asia and into Australasia. And I've just put in 3 different types of bariatric surgery here. This is taken from a publication I did several years ago. And there are lots of other types, but I just wanted to highlight the gastric band, the gastric bypass, and the sleeve gastrectomy. The gastric band is going more out of favour now. It is reversible, but it's also easier for the person to play around with the port, the filling of the access port. So it's fallen out of favour a little bit. Gastric bypass and sleeve gastrectomy are incredibly popular. The problem with sleeve gastrectomy is that it is non-reversible. And bariatric surgery, the procedures of all of those bands, bypasses, and sleeve gastrectomy are increasing across the States since 1992. And the good thing about bariatric surgery and diabetes is that it causes almost a complete reversal of type 2 diabetes. And this is a very nice quote which comes from a very recent report which was in JAMA just this year. An extraordinary thing happens when some patients with type 2 diabetes who undergo weight loss surgery, within days of the procedure, they improve their insulin production and need fewer or no diabetes medications. So bariatric surgery, if diet's not going to work or is going to be too difficult to do, bariatric surgery does work. And the bullet points underneath this are just from one study. There have been many studies since. This is actually now quite an old one, which shows that the weight and BMI decreases very rapidly. Your fasting plasma glucose, your HbA1c decrease to normal levels in 83% of the patients that were studied in this particular study. I think it was about 3,000 people they looked at in this one. Oral anti-diabetic agents are decreased, the use of them by 80%, insulin by 79%. And these decreases in the insulin medication happen incredibly quickly. There's some anecdotal evidence to say that it is within a matter of days. The patients who respond the best are those who've got the shortest duration of diabetes, so under 5 years, who are diet controlled rather than on medication, and who also the ones who have the greatest weight loss after surgery. They're the ones who are most likely to see resolution of their type 2 diabetes. So is bariatric surgery actually the cure? Well, no, because there are a lot of complications associated with bariatric surgery. I've just taken some of them here that you'll be familiar with. Some of them are surgical, some of them have to do with hypoglycemia, and of course some of them have to do with malnutrition because of absorption issues of some vitamins and minerals. And there is other evidence with regards to things like stomach perforation and ulcers. But there is another complication of bariatric surgery which I think is routinely underreported, if you like, and that's suicide rates. Because the suicide rate in people who have had bariatric surgery does actually increase, and it does increase significantly. This was a big study that was done. This had been originally shown in the Swedish obese subjects study, but this is a bigger study where they looked at just shy of 9,000 patients. Now, it's important to note that the majority of these patients, the vast majority of these patients, are female. And they showed that the number of self-harm emergencies increased after surgery, and it increased significantly. They were higher amongst patients who were older than 35, who came from a low income status, and importantly, those living in rural areas. The most common self-harm mechanism was intentional overdose, and I think that's reflected in the fact that the vast majority of the people are in this particular study are female, because in females that is the preferred suicide method of suicide compared to men who prefer to use more violent means. So a total of 147 events occurred in patients diagnosed as having a mental health disorder in the 5 years prior to their surgery, which just highlights the importance of having a really, really robust psychological workup in patients before their surgery, but also after their surgery. So let's say that it's not your fault. Let's take another viewpoint on this. And let's say that actually, maybe it's society's fault. Is it society's fault that we're all getting morbidly obese now? And there is some evidence to suggest that, and these are just pictures that I've gleaned from the internet. We have huge access to much cheaper, very highly calorific food and a lot of very processed food. We also tend to be much more sedentary now. We take cars instead of walking, and we lounge around on the sofa in the evening watching the television. And this has hit the news headlines in the UK. We've had a child who was just 3 years old, who died from obesity. And this was reported in the Daily Express. And for those of you who know the UK media, you'll know that that's perhaps not the best newspaper to be reading. But if you look at the on the right-hand side of the of this, you'll see that even the broadsheets, the slightly more informed, less hysterical newspapers in the UK, like the Daily Telegraph and the Independent, also reported this. This caused a huge amount of news in the UK, and rightly so. So what are we doing to try to overcome this? Well, we're trying food labelling, and there was the lovely talk that we had just before mine from Dr. Omar was talking about this traffic light system, and we're using this traffic light system quite routinely now. You can see in the bottom right-hand corner, things that are in green are good. That's okay. They're within daily limits. Things that are in orange, there's a little bit, or amber, a little bit more concern there. So you should be mindful of that. The things that are in red, that's a no-go. You shouldn't be eating too much of that, because this particular thing is very high in fat and very high in saturated fats. But even if you do food labeling, it's actually not that easy to find on quite a lot of foods. And I thank Professor David Matthews for this slide, who went out and bought a Mars bar. And in order to find the calorific input on that, you have to turn it over, lift the little flap, and try to take a photograph of the food labeling that's inside of that. And it's actually quite difficult to do. And whether, once you even see that, if your patients are going to understand what is in there, because it's tends to be written in kilocalories and kilojoules, is a matter for debate. Now, this is a video. I normally show a video when I'm doing a talk like this. I didn't put the video in, so these are just screenshots. So we have food labelling, and that's fine. But we also have a big issue with portion size. Now, I'm afraid I'm going to highlight McDonald's here. There are other burger chains available. But this video on YouTube has been looking at how portion size has increased over the past 40, 50 years. And you can see that the average hamburger was about a third of what it is now. So in the few years since McDonald's has started, the size of hamburger has increased. So has the size of the fries that you get. In 1955, there was only one size of fries. That was all you got. Now you have small, medium, and large. And the same goes for diet drinks, for sodas. And as you know, that it's not always diet drinks that are available in some of the fast food joints, and they have extremely high sugar content. So portion size is a huge issue. And in the States, they've now started doing calorie indicators, and New York has led the way on this. And New York, for all of their fast food outlets and a lot of their restaurants, they actually show you the calories for everything that is on the menu. Now, the one on the left-hand side you can't see terribly well, apologies for that, that was my bad photography. The one on the right-hand side, you can see that the calorie counts are actually in there. So does that work? Well, there's been some new research which shows that in a number of restaurants, they looked at 15 of the largest fast food chains in New York. They interviewed people 3 months before this legislation was passed and 3 months after the legislation was enforced, to see if having the calorie counts there actually made any difference at all to people's purchasing. And before this became enforced by law, 25% of customers reported seeing the calorie information. 3 months after, that rose to 64%. And among that, the group of people who had reported seeing the calorie counts, about somewhere between a quarter and a third said that they were using that information to make informed choices. So since the enforcement, using this data and extrapolating out, they think that approximately 1 million New York adults see calorie information every day. Now, whether this will have an effect on obesity, New York has huge issues with obesity. Whether this will actually make a change or not to obesity over the next few years, we have yet to see. But there is, of course, a third chain of thought. So let's say it's not your fault. Let's say it's not society's fault. Is it, in fact, your parents' fault? Which is why the English philosopher Bertrand Russell said you should always choose your parents wisely. Because even in the midst of an obesity epidemic, which we are currently in the middle of, and we're in an environment which is termed obesogenic, so there are a lot of things that are encouraging us to put on weight. What are the factors that determine why some people actually stay slim? And a lot of people do stay slim even in these environments. So are the lean actually biologically, are they just biologically different or simply morally superior? And there's some very nice work looking at dizygotic and monozygotic twins, looking at the genetic determinants of body weight. And if you look at the bottom of the panels there with the monozygotic twins, this study was done where the twins, either mono or dizygotic, they were born and then they were adopted. They were raised apart, so they were raised in very different environments. And you can see that the monozygotic twins, their phenotype stays the same. It's almost identical regardless of where they were brought up. If you look on the upper panel, on the upper right-hand side, you can see that dizygotic twins, so not genetically identical, brought up in different places, have very, very different phenotypes. And there's been a lot of work to suggest that the heritability of BMI is between 60 to 80%, which, as I said, is why you should choose your parents wisely, because that heritability remains even in the midst of an obesity crisis. And this piece of work by Jane Wardle and her colleagues showed that there is a very, very strong influence on childhood adiposity. And the very last sentence of this paper I like. It says that the epidemic of obesity is attributed squarely to changes in the environment, whereas individual differences are attributed to genetic differences between individual people. So what are the genetics of obesity that we know thus far? I think the big one, and you'll be familiar with this, is leptin. And leptin was discovered on the, if you look at the picture of the mouse on the upper left-hand side, this is the OBOB mouse. The OBOB mouse is used a lot, but it really wasn't until quite recently, relatively recently, that we knew what the gene was that made this mouse as fatter, in fact, than two of his non-obese litter mates. And lovely work by Jeff Friedman's group in the States identified that the one gene that was responsible for making the OBOB mouse as fat as it was and to have the insatiable appetite that it has is leptin. This work was also the first work to prove that adipose tissue is actually an endocrine tissue and not simply a byproduct of our rather sedentary lives nowadays. So leptin is a really key protein which works in relation to fat mass. So when fat mass drops or fat mass increases, leptin will go the other way to ensure that energy is expended in such a way that that fat mass is repaired to the level that it was at before. And it works very, very nicely to decrease your food intake because it's a satiety hormone, one of many that have now been discovered. And it's not just in mice that we've found these mutations, because in I'm not going to talk about the PC1 deficiency, which is on the left-hand side. We've just focused on the right-hand side of this. This was a family that were discovered in Birmingham. They're of Pakistani origin. There's been quite a few different families discovered since, including a couple of Egyptian children who had a nonsense mutation in the leptin gene. But that little boy at the time of this picture was about 2 to 3 years old, and he was taken into a research facility at Addenbrooke's Hospital in Cambridge, and he was fasted overnight. I'm not quite sure how they managed to fast him, but they did. They fasted him overnight, and then in the morning they gave him free access to cafeteria style diet to breakfast. And the boy at age 2 ate 2,500 calories for breakfast. 2,500 calories is the calorie intake that we would recommend for an adult male. The only time that he stopped eating was when you looked in his mouth. He physically could not get any more food in. He had such excessive hyperphagia. And the parents of these children had to padlock the fridge and the freezer every night, because the children would get up and would eat food, and they would actually eat frozen food. They would eat whatever they could get. So they had to control the availability of food in the house. That little boy had a leptin deficiency, had a mutation in leptin, which meant that leptin didn't work, which meant that he just continued to eat. He was given leptin injections, and over the course of 3 years, you can see that the little boy moved from being very obese, from being morbidly obese, to being a normal phenotype for a little 6-year-old boy. And it's now recognized that about 5% of all cases of obesity will be monogenic. They'll be caused by just one gene, a variant or a mutation in one gene. Leptin is one of the ones that is best characterized, but there are issues with mutations and variations in the leptin receptor, and that leads to something that's very similar to insulin resistance, where you have leptin resistance. So leptin injections don't work as well in people who've got mutations in the leptin receptor. But there's very nice work coming out now which shows that if you do injections of leptin and amylin, that works quite well in people who have leptin receptor mutations. A whole raft of other genes coming out, sort of the brain-derived neuropathic factors and whatever. These are all monogenic conditions, and they're all characterized by this excessive hunger and hyperphagia. So is obesity actually in the genes? There's another work came out a few years ago now, and this is a sort of a collation of a lot of work on FTO. And some of you will be familiar with the FTO gene, the research around it. And if you look at the knockout, this is all done in mice. If you look at all the knockout and neural-specific knockouts, you'll see that body weight is decreased. And that's exactly what you would expect. You would expect to see increased energy expenditure, which you do except for one case, and you would expect to see increased food intake, which you do except for one particular experiment. With regards to fat and lean mass, you'll see that there's slightly more variation there. Some are decreased, some are increased, and some are not affected. But the FTO gene is an important one. And has it been shown in people? Yes, it has. It has been shown. And this is the work of Andrew Hattersley and Tim Frayling at the University of Exeter, in the Plymouth Medical School, at the University of Exeter. And they've shown exactly the same thing. So if people are heterozygotic for the FTO gene, and around 40% of people are, they will carry 1.5 kilograms of fat more than people who don't have the variation. And if you're homozygotic for the FTO mutation, you will carry 3 kilograms more of weight. And the FTO gene is now just one of a huge raft of genes that have been discovered through GWAS, through the genome-wide association studies that are going on, a huge effort going into this around the world. And you can see that they're all being classified now, and they're being classified in a number of different ways. It's a rather complex Venn diagram. The vast majority of genes that are being discovered now are associated with obesity and BMI, and they're in the red circle. If you look at the ones that are in the blue circle, they tend to be associated with waist circumference. The ones in the green tend to be put you at an increased risk of childhood obesity. The ones in the sort of paler red or pink are associated with fat mass. And then, of course, the large ones at the bottom, which is in the yellow circle, they tend to be associated with waist-hip ratio. And you can see that the FTO gene, which is one of the first one, with the exception of leptin, one of the first ones that was identified in humans, sits right at the very heart of that. So what have I shown you? I've shown you that there are a huge number of different variables that are affecting people becoming fat. Now, I'm becoming obese. I've not gone into all of these because I know that time is of the essence and lunch awaits, which is probably not appropriate timing to have a talk on obesity. There are a number of intrinsic variables, which is satiety, which is hunger, which is genetics, which is programming. There are a number of largely extrinsic variables, and I spoke a little bit about that, about food availability, palatability, portion size. I didn't talk much about food advertising. And then there's a whole raft of complex variables, which I did not go into at all today, looking at the sort of hedonistic effects of food and how mood can affect diet. There are intrinsic variables like metabolic rate, there's thermogenesis, and of course physical activity. How does that, that's a complex variable, how does that affect everything? And other extrinsic influences to do with our sedentary life and how our exercise, our physical activity during the day can affect our food intake. So I've tried to show you that there are really three schools of thought. There is the school of thought that says that it's your fault. There's the school of thought that says that it is society's fault. And there's a school of thought that says that it's actually genetics. And I think that what you said to me at the beginning was that it was a complex arrangement of genetics and environment is absolutely correct. And I think that is what's driving the epidemic in diabetes and in obesity. And I think that whilst more environmental factors may well be teased out, I think that over the next few years we will see a lot more genetic variants and mutations being implemented in obesity. So I will finish there. If you have been, thank you very much for listening.
Thank you, Dr. Thank you. By the way, our obese diabetic patient need at a certain time, correct time, a bariatric surgery intervention to do bariatric surgery at a certain time. Would you you agree, Dr. Omar?
Question again, please.
Our diabetic obese patient will need at a certain time to do a bariatric procedure to control weight, diabetes, and for healthy joints.
Yes, if he can afford it. That's what I say. If he can afford it and find somebody who will help him, yes, it would be very good. By the way, my brother did one last year. He was 182 kilograms. Now he is 75. But it's a terrible operation. He can't eat very small portions, and if you stress over it a little, he's going to vomit. But it was life-saving.
Thank you very much for all the three lectures were fantastic actually. My question is for Dr. Eleanor Kennedy about the existence of what's referred to as healthy obese. Is all the fat bad fat? Is it we consider visceral fat to be responsible for the metabolic syndrome, including type 2 diabetes? We are used to know that subcutaneous fat is completely innocent. Is it really completely innocent, the subcutaneous fat, or are there some data accusing subcutaneous fat as well? Because some patients are thinking merely about the shape and they are asking for a liposuction or abdominal lipectomy to solve the problem. Is there any new data about suggesting that subcutaneous fat is also, maybe also accused, and the entity of the healthy obese? And thank you very much.
Okay, that's a really good question. So just to reiterate, this is about the difference between visceral and subcutaneous fat, and I think there is a danger of saying that one type of fat is healthy and one type of fat isn't. I think fat is fat, and it isn't that healthy. We need a little bit, to protect organs and whatever, but we don't need as much as we've got. So I think it's a bit of a misnomer to say that there is healthy fat and unhealthy fat. The research around that is actually not that strong. Interestingly, there's not been that much research done. Now, there is some that I know of that's underway, but I haven't seen the results of that yet. So I'm not sure that I could really answer that question to that point. What was the second part of your question? There was a second part. Oh, the healthy obese.
The healthy obese.
Yes, and again, I think that is a bit of a misnomer as well. I don't really like the term healthy obese. I think they're regardless of where your fat depositions are, regardless of how much you think you're doing or how well you're eating, I think they're obese is obese and healthy is healthy. I don't think there is such a thing. I'm not a great fan of the term healthy obesity. I'm not sure if that helps.
Thank you, Dr. Olu. Now we close our session. Any question? واضح السؤال لمين؟ The question to whom?
For Dr. Leszek. For Dr. Leszek.
Okay.
Must we screen patients for ischemic heart disease before starting?
Sorry, didn't get it.
Yes, here.
Oh, well, must we screen for?
For the diabetic patient for ischemic heart disease routinely without any manifestation or not?
No, there was a like 10 years ago, this was the suggestion that all diabetic patients should be actively screened for coronary heart disease. But the major study which gave us the answer, the Barry study, showed that actually if there are no symptoms whatsoever, any early screening or any early intervention doesn't, again, prolong life. So rather not. We don't screen it by exercise tests or angiography routinely. But we remember and we look for symptoms for sure, because they are at greater risk. But patients who are asymptomatic are not basically screened or treated nowadays, because it just didn't yield any benefit.
Sometimes we found a case completely normal ECG, completely all health says ECG normal, says echo normal, and the patient die of cardiac insult. You saw this patient? No. Any question?
For Professor Leonor, I ask about the drugs used to decrease satiety and their role of treatment of diabetic patient. Do you think about that?
When it comes to the drugs that, so the question was about the drugs that are used to decrease satiety. Now that's not my background at all. I'm not a physician, so the actual drugs that are used, I'm not so familiar with. I don't know, Leszek, do you want to pick this one up?
Well, there is a constant failure in finding a drug which will limit the appetite and help people lose weight. We have the drug occurring in the market, they stay there for a few years and then clearly they cause some side effects and they disappear. I already mentioned dextromethorphan, sibutramine. There is the lipase inhibitor, which is relatively weak. The newest or the latest addition is the drug, which is a compound drug with topiramate and naltrexone, which acts centrally and decreases appetite. The problem is, I have one, as a physician, I have basically one problem with obesity pharmacotherapy. It only works as long as it is used. So you may prescribe, well sibutramine was very successful for quite a few years. But the moment the patient, it was very expensive as well, never reimbursed, very few countries. So when the patient started to take sibutramine, they lost weight. And they thought, okay, I've been taking it for 6 months, spending money, I can stop. My weight, I lost 10 kilos, I'll stay like that. They never stayed like that. They always regained the weight, and sometimes they were they regained more than they were weighing at the baseline. So when the studies occurred, when the studies were published with sibutramine, the longest observational, well, the longest study which confirmed the safety of the drug was 2-year duration. So then I told the patient, okay, I can prescribe you sibutramine, but only if you can afford to buy it for 2 years, because then this is safe, and perhaps for 2 years your food eating behavior might change enough so you will maintain your body weight. Very few people continue for 2 years. So I'm not much in favor in pharmacotherapy, because it's a short solution. It doesn't really solve any problem, and if you go deeper into the physiology of food intake regulation, there is I have a nice slide, not here, but I have a nice slide showing from the paper 15 years ago, showing I think about 30 different compounds being prepared by the companies to be put on the market. None of them enter the market. The food regulation, food intake regulation is very complex. You can block one receptor or one agent, there will be 20 others stimulating appetite. We are designed to survive any famine. If there is no food around, you will kill your neighbor and you would eat him just to survive. This is how strong this is. So, and just another example like dopamine. Dopamine in low concentration is orexigenic, in higher concentration is anorexigenic. So how can you play around these compounds? I don't really believe we will ever have any kind of pharmacotherapy which you can take and it will lose weight safely long term. Yes, and probably the safest drugs now we can use for weight loss and register for weight loss is liraglutide, GLP-1 receptor agonist. But again, you will only lose weight when you take it. The moment you stop taking liraglutide, and it's registered in double the dose for obesity treatment than in diabetes. It's called Saxenda, 3 milligrams per day. The moment you stop taking it, you will regain the weight. So it's rather changing because you told about pathophysiology and you told about the causes. You said very little about the treatment. So I can tell you I guess in my whole career I managed to help lose weight, I think 5 or 6 patients effectively, 5 or 6 patients. And when I wonder recently what was the reason, the only reason they were successful is that they came to me with a whole family. It was the obese man who came with a wife. They changed the way they cook, they behaved in the family. The wife, then she was a little bit angry. I told them what to do basically with the food eating things and what they should eat, how they should behave, because we're good in theory what you should do to do it. But then the wife of the most recent patient was angry with me because she said, look, I'm slim and I lost 7 kilos. And she said, sorry, it's probably, I'm not sure if it's very appropriate, but she said, look at my boobs. I look at my face. I look older. I lost 7 kilos. My son, our son, the son was 13. He lost 4 kilos, although we didn't aim him to lose weight, but we changed the whole way we cook, we behave at home. So that's probably the only way, not the drugs. But of course the companies will be producing them and will be making a lot of money, but it's just buying hope for short term. They will never work permanently.
I know في ترايل اللي هي توليستي المفروض النتيجة بتاعتها هتبان قريب يعني. سمعت عنها؟ توليستي. ها؟ study لسه شغالين فيها يعني. New emerging drugs under trial. دكتورة إيناس.
Thank you very much. Two or three actually very important and very effective workshop and course, and please we all should give our appreciation to the EASD, the European Association for the Study of Diabetes and Metabolism, for the effort, for the time, for the sponsorship, for everything. Thank you very much, and thank you, Professor Leszek. Thank you very much. On behalf of all the attendants and on behalf of the EASD board and members, we thank you very much, and we hope to repeat these activities if EASD will allow us. So thank you very much. And please, can you give the closing remarks? Thank you very much.
Yes, Professor Inas and dear friends and colleagues, the faculty members, we've just finished our first ever course in Egypt. As I said at the very beginning, we are delighted to be able to come here. We organize over 10 courses per year, which is quite a lot. We're always delighted to come to new places. We're on the lookout for the new locations. It is always a challenge because we only start getting to know the people we usually get to know very well through emails, but in person we meet here. So we're always a little bit unsure, how is it going to happen? Will you be interested? Always the biggest worry for us is the attendance, especially that this is an exciting city. We are right in the center, and probably you could find something more interesting to do than being here. These are our worries. But we were delighted you stayed with us all the time, and we had a wonderful time interacting with you, because the main value of our courses is not just that we bring bunch of European speakers and they share their knowledge with all of us. The value is in ability to interact with you during the lectures, workshops, but also during the breaks and the mealtime and in the evenings. So as much as you learn, I hope you all learn at least a little bit here. We also learn by coming here. We see the different perspective for how diabetes is treated in your countries, in your communities. We see the challenges you are facing. And believe me, we go to places you might think they are exotic. In last 2 years, we were as far east as in Vladivostok, we were in Mongolia, we go to Central Asia, Caucasus, we're always present in the Arab community, we go to the Gulf countries, we go also to places like Iran. We planned to go to Iraq, but we were stopped by a political situation there. And the amazing thing is that as much as we live in different cultures, also medical cultures, as far as we have different access to medications and services, when you talk about your patients, you sound exactly the same as all other colleagues all around other places we go. People with diabetes face the same sad fate and face the same problems. There are the same questions. What should I eat? How should I behave? How should I adjust my medication? And so on and so on. So we all together try to answer these questions from our patients. We are strongly convinced that whatever we do with you at postgraduate courses will be translated into the benefit for our patients, because that's what's the most important thing. We enjoy being here immensely. Thank you very much, Professor Ines, for wonderful organization, very professional. I can tell you this is the most magnificent screen we've ever had at our courses. So every one of us who came here said, wow, what a screen. So all the technicalities, all the cameras, this is not a big room, but this also helped to take part in the meeting, all of us. So again, thank you, and thanks to the Arabic Association, because it is also a unique thing. Whenever we come to a new place, we basically need one person to collaborate with. This must be a one trusted liaison person, and Professor Ines was this person here. But she's the president of the regional association, so we are even more proud that we were able to collaborate. We have a very good example of collaboration with a similar organization, which is Gulf Group for the Study of Diabetes, with our colleagues from the Gulf region. An extremely successful collaboration. It's also together with one of the companies. We meet there every November or early December, once a year. Also the countries with very high prevalence of diabetes. So sometimes it's a local national organization, but very often it is just the leading person in the region who's the head of the local endocrinology department, who simply wants to do something for their colleagues and for the patients by inviting us here. So this happened here. As I said, we're extremely happy. There are not only colleagues from Egypt, but majority of you are from here, which is the main task where we go. We also have colleagues from Syria, from Pakistan, other countries. So that's from the Palestine. We also try to serve the whole region. So once again, thank you very much. Thank you to all the faculty members. Thank you to Brian and Karen from the EASD office. They are those silent heroes of all our courses. They keep quiet. They don't have any talks but without them we wouldn't be able to do anything, because all the logistics on EASD side is handled by the team in Düsseldorf, and the team is led by Brian Carey, whom you met here. Thank you to all the technical company which really served and did great job with this, having been a wonderful opportunity to educate. And I'm pretty sure this is the first time we've come here, but I'm pretty sure it's not the last one. We'll be delighted to come again. Thank you very much again. Shukran.
Attendees are very enthusiastic to attend more and more courses, and I'm sure next time, whether in the course or in the AASD conference, you will find crowdness, thousands, because we had thousands of applications, but we tried to filter them and to minimize the number. So I'm sure Egyptian doctors will benefit a lot, and they are very appreciating. Thank you very much.
Thank you. Thank you very much. Okay. This is it? Yeah.
Another group photo for those who didn't attend yesterday, because some of the colleagues asked for another one. So the photographer, please, Mr. Zain. Would you please come to the stage for another group photo? You want to open the curtains? الستارة يا جماعة لو تحبوا تفتحوها الستارة. دكتور لاشك.
Yeah, I'm coming.
دكتور لاشك. دكتور لاشك. دكتور سيد. Can you سيبوا له مكان. اوكي طيب حركوا.